Case presentation. The biographical data. The name of this patient is Mrs. J, which is not her real name. The age of this patient is 65 years old. The gender is female. Race is Malay. The date of birth is 7th of August 1952. The address is at Lundu, Sarawak, and she is Malaysian, and she admitted at the hospital on 19th of October 2017. The chief complaint. The patient complained of fever associated with chills and rigor, passing out loose stool for 3 days consecutively, abdominal pain for 2 days consecutively days, lethargy for 2 days, reduced oral intake for 2 days consecutively, and having shortness of breath 2 days consecutively at home, and having reduced of urine output. While, for the presenting symptoms for this patient, she is drowsy but oriented to time, place, and person. Her capillary refill time was less than 2 seconds and having poor pulse volume. Upon arrival, her blood pressure dropped to 84/45 mm mercury. Her pulse rate increased to 118 beats per minute, and the temperature is 37 degrees Celsius. The oxygen saturation dropped to 88 to 91%, but after put on the nasal prong, the oxygen saturation increased to 95 to 100%. For the past health history, this patient having chronic kidney disease stage 4, hypertension, and type 2 diabetes mellitus, also dyslipidemia. This patient's past health history was diagnosed during her admission at the hospital. This is because this patient did not go to the hospital all this time. While for the health assessment, the lungs are clear, and upon auscultation, the inspiratory and expiratory rate is equal for both lungs. No pitting edema identified when the pressure applied to her limbs to identify if there is any edema. Conscious, but she is weak on her lower limbs, so she is activity daily living is dependent. The Glasgow Coma Scale for this patient is full. The summary of clinical examination. Firstly, for the ABG test, on 19th of October 2017, the ABG is partially compensated metabolic acidosis, which is the acid is accumulated in the body due to increased acid production or acid indigestion in the body. So, the example of disease for this kind of ABG is ketoacidosis, renal failure, toxic ingestion, or septic shock. While on the 23 of 2017, the interpretation for the ABG is normal. While for the hematology test, on the 19th of October 2017, the white blood cell is high due to increase to fight for the infections, and the red blood cell is low, and the hemoglobin is low, the hematocrit is low, the low platelet is low, and the protothrombin and the INR also low, and the activated partial thromboplastin time also abnormal. On the 23rd of October 2017, the white blood cell is high, the red blood cell is low, and the hemoglobin is low, the hematocrit low, and the platelet also low. The red cell distribution wise. The biochemistry report on 19th of October 2017, the chloride is low, the urea is high, the calcium is low, and the creatinine level also high, and the phosphatemia is high. The direct bilirubin is high, and the ALT is high, and the albumin is low, and the alkaline phosphate is high, and the globulin level is high. While for the blood film and malaria parasite, it is found out that it is appeared to be negative. The serology laboratory report is negative also. This means that the patient does not have any leptospirosis.
Disease process. Patient was diagnosed with septic shock secondary to acute pyelonephritis. Septic shock is conditioned as a result of severe septic and hypotension. This is occurred due to the interaction between the infecting microorganism and the response of human host. Her sepsis was initiated from the pyelonephritis, which is the infection of kidney. When the infection enters the bloodstream, this causes sepsis. Sepsis will cause changes the function of endothelial tissue in coagulation process and also changes in the blood flow. These changes will trigger the production of pro-inflammatory mediators, cytokines. The cytokines will cause neutrophil endothelial cell adhesion. The neutrophil endothelial cell adhesion may cause injury to the endothelium. When there are injury, clothing mechanisms are activated. This combination may impede the blood flow and cause the vessel to leak. The leaking of vessel may result in fluid and microorganism escape to the surrounding, causes tissue to swell. This results in edema. The cytokines also causes arterial vasodilation and decreasing peripheral arterial resistance result in decreased blood pressure, or we call it hypotension. Decreased perfusion also may cause the dysfunction or failure of some organs such as kidney. Airway management and oxygen therapy. Patient was intubated upon her arrival in Sarawak General Hospital due to her condition become more restless. Patients are then inserted into ICU for mechanical ventilation. Patient was put under mode of SIMV mode, volume control first. SIMV mode or synchronized intermittent mechanical is prefix volume control was prefix set, and if patient has breathing, this mode will synchronize the breathing, synchronize the inspiratory. Patient was then put under PSV mode, which is more to patient effort. PSV or pressure support ventilator will give constant positive pressure during patient inspiratory. As patient condition become more stable and conscious, extubation was done on the 23rd of October. Circulation management. Patient was given intravenous drip of normal saline bolus of the total of 5 pint from Lundu to HGH. This is as her fluid resuscitation as she was undergoing shock. Lines are also inserted to ensure that medication and drip can be inserted to the patient. CBD are also inserted to monitor her urine output. Imaging tests are done to get the diagnosis of the patient. Plain CTU was the result from the plain CTU confirmed the patient are having septic shock secondary to acute pyelonephritis from the finding. Dialysis are done due to her renal failure. Hemodialysis act as same as kidney function, which is to filter and excrete waste product. Double lumen catheter was inserted at her right femoral. During hemodialysis treatment, patient condition are worsening as her BP blood pressure become low. She cannot tolerate the treatment, and doctor decided to terminate her treatment after 2 hours. Doctor then planned start CRRT, which is continuous renal placement therapy. The CRRT treatment also same as hemodialysis treatment, but this treatment work in a slow and continuous for 48 hours. Other management are blood transfusion, diabetic, and nutrition are also given to patient. On 20th of October, patients are having anemia, which is low hemoglobin. Doctor ordered to transfer 1 pint of packet cell to the patient. The transfusion was successful over 4 hours without any reaction such as headache, loin pain, and so on. To treat her diabetic, patient was put on the insulin sliding scale in order to control her blood glucose. Pharmacology management. To treat her shock, patients are given inotropes such as IV adrenaline, and also IV dobutamine. This is to treat her blood pressure and her heart condition. The titration of dosage of these inotrope drugs are changes according to her blood pressure condition. Patients are under sedation during in ICU. IV midazolam and IV fentanyl were given to keep sedate her and to reduce her pain. For her infection treatment, IV ceftriaxone are given as antibiotic and IV hydrocortisone to reduce inflammation of the kidney. IV furosemide are given as her urine output was low.
For nursing care plan, the first nursing diagnosis is ineffective tissue perfusion related to maldistribution of circulation blood volume as evidenced by presence of weak peripheral pulse and decreased blood pressure of 88/62 mm mercury. The first nursing intervention is to assess any other sign and symptom of decreased tissue perfusion, to evaluate further interventions needed, assess the strength and quality of peripheral pulse to determine the pulse rhythm that may due to sustained hypoxemia, monitor the non-invasive hemodynamic closely such as blood pressure, heart rate, capillary flow and others to obtain and establish precise diagnosis and baseline data. Encourage patients to perform active or passive range of motion exercise to prevent circulatory compromise and strengthen the muscle. Administer intravenous fluid as ordered such as normal saline 0.9% to restore blood volume of body. Administer vasopressor and inotropes as ordered such as noradrenaline and dobutamine to maintain adequate perfusion pressure and cardiac output. The second nursing diagnosis is impaired skin integrity related to administered medication and disease process as evidenced by skin discoloration, necrosis, and swelling on both legs. The nursing intervention include assess skin characteristic and integrity of both developed and affected necrosis area to determine the extent of injury and evaluate further intervention. Teach patient and her family members to perform proper hand washing technique to reduce transmission of microorganisms, perform wound dressing care on to patient as needed to promote healing process and for hygienic purpose. Encourage patient to consume high protein and caloric diet such as eggs and cereals to boost healing process. Administer steroid medication as prescribed, such as hydrocortisone to reduce the inflammatory response to body. Administer antibiotic medication as prescribed, such as ceftriaxone and flagyl to treat bacterial infection. The third nursing diagnosis is risk for fall related to generalized weakness on both legs to ambulate. The nursing intervention is elevate the bed rails and keep bed in low position to avoid risk of fall. Elevate both legs above heart level by using firm surface such as blanket or pillow to promote blood return and decrease swelling. Advise patient to rest in bed to reduce fatigue and unnecessary movement. Assist patient to perform activity daily living such as ambulating, dressing, bed mobility, transferring, toileting and bathing to enhance spiritual and physical wellness. Consult patient with rehabilitation specialists to provide activity and exercise for strengthening the muscle.